Hi, this is Chris Lodge, and this video is going to describe the domain modelling of pre-exposure prophylaxis, or PrEP, for HIV. I'll start with some background information for HIV and AIDS. Human immunodeficiency virus, or HIV, is a virus that weakens the immune system. There is no vaccination nor cure for HIV, but we do have medication that is effective at treating and suppressing the viral load. If HIV is left untreated, it may progress to acquired immune deficiency syndrome, or AIDS. Patients with AIDS are extremely susceptible to infections which can be fatal. Due to how HIV can be transmitted, it disproportionately affects certain populations. The largest group affected in New Zealand is men who have sex with men, sometimes referred to as MSM in medical literature. This is demonstrated by this graph, where MSM is represented by the largest blue bar. HIV is a very large and complex clinical topic. This is just the very start of a mind map for HIV. One of the sections I fleshed out a little is the strategies to prevent further infection. Despite education and promotion of condoms in the MSM population, HIV incidence continues to rise. The section I am focusing on is the antiretroviral treatment. There are 4 uses of antiviral therapy in HIV: the treatment of confirmed HIV, the prevention of maternal exposure, post-exposure prophylaxis, which is a short course taken after exposure to a HIV risk, such as needle stick injuries or high-risk sexual activity. The last section is the one I'm going to be focusing on, which is pre-exposure prophylaxis, or PrEP. PrEP in New Zealand consists of 2 medications taken as a single pill with a dose of 1 tablet once a day. A potential starting point for my domain modelling was looking at SNOMED-CT. SNOMED-CT details clinical classifications that can be used so systems can exchange data in an interoperable way. There are different releases for different geographical locations. The first one is the Australian release. We can see that PrEP is categorised under antiviral prophylaxis. When I zoom in and expand that tree, we can see that PrEP is also listed under the same category. Compared to the UK, where PrEP is its own individual category and has subcategories related to daily regular dosing, or event dosing, where medication is only taken before high-risk activities. In New Zealand, only daily dosing is funded. Neither the international or US releases have PrEP listed, only PEP. These are older releases, however. In March 2018, Pharmac funded PrEP through a special authority requirement. In New Zealand, this means patients have to meet certain criteria to have the medicine subsidised. The Pharmac criteria is based on evidence-based medicine. The common guideline used in New Zealand is the Australasian Society for HIV Clinical Guidelines. There are different criteria for initiation and renewal. Initiation has to be done by or on recommendation of a named HIV specialist, but renewal can be done by any relevant practitioner. This is what the paper form looks like. It is quite complex and has a range of or and statements which can be confusing for people to interpret. For example, this person does not qualify for funding despite having many of the boxes ticked. There are a few reasons why I believe a decision support tool will be helpful. Overall incidence is relatively low and the medication has only been funded recently, so general practitioners may not be very familiar with this medicine. As demonstrated, the pharmac criteria is complex, and HIV infections are a financial burden on the healthcare system. PrEP is financially beneficial as the cost for prophylaxis is much smaller than the cost to treat an infection. The next mind map now focuses on my clinical topic. One obvious subheading is the pharmac criteria, which is built on evidence-based medicine. My other subheadings are the target audience, inputs and outputs. The target audience is GPs and other prescribers who are not specialists in HIV medicine, but I acknowledge this tool might also be used by the specialists, so it needs to be designed with this in mind. In the interest of time, I haven't mapped lab results in further detail. This example from OpenEHR talks about the HIV positive finding and goes into further detail. Focusing on my inputs, these can be broadly categorized into two groups. Those that involve data, i.e. a measurement, which could theoretically be imported from an electronic source, and these are coloured yellow. And then patient behaviours, which are tacit knowledge to the patient that must be made explicit for it to be used in a decision support system. These are coloured purple. I'm going to focus on one particular element which demonstrates the specific challenges of this patient population and use of data. This is gender and sex. Gender and sex are often used interchangeably in language but have different meanings. Sex is based on anatomy and is assigned at birth, whereas gender is how a person perceives their own sense of being a man, woman, both, or neither. OpenEHR has a very detailed concept on gender that I've displayed here, which illustrates just how complex it is and the number of fields an electronic system will need to cover this concept accurately. Each comes with its own definition, which are detailed here. It is important to note that this excludes sexual orientation. Many systems have a single field for sex or gender, so this is going to be important for my decision support tool. Based on the criteria, funding is dependent on being male or being transgender. If a system only has sex as a data field, this excludes a particularly vulnerable portion of the population. Going back to the mind map and looking at outputs, the main output is the recommendation of whether the funding criteria is met or not. The funding is, however, dependent on other tasks, such as giving advice to the patient on HIV and STI risk reductions, so these also need to be included. I'm going to finish with some general considerations for how this decision support tool should be developed. Ideally, the system would integrate into the GP management system rather than being a standalone tool, and it would be beneficial if lab results could be integrated directly. Both of these are substantial challenges due to the variety of patient management systems. As discussed earlier, we're unlikely to be able to rely on sex and gender from any electronic source. There are two specific patient groups to consider further. One is patients who are ineligible for PrEP but are willing to pay for it. In this case, the pharmac funding criteria and therefore the proposed decision support system also function as more of a clinical safety checklist than a recommendation for funding. We should also be aware that patients that meet most of the criteria may be untruthful about sexual behaviour, so they fit the funding criteria. In reality, they may be practicing safer sex than they admit to meet the funding criteria. These are my references. Thank you for listening.